Okay, week number 10, ankle. As with each week, we're going to start with classifications. We're going to do ankle stability and movement coordination deficits, which is more like an ankle sprain. Muscle power deficits, which is more of a tendonitis or a bursitis. Ankle foot radiating pain, which is more of a tunnel syndromes, tarsal tunnel, Morton's neuroma. And then ankle mobility deficits, which is more post-traumatic or an OA ankle. Also want to make sure we go through, just review with them the importance of taking a really good subjective exam. Some examples might be the history, determine mechanism of injury, was it an overuse injury, how did the injury occur, any popping, snapping, was there any changes in their training, the surfaces, any back pain, leg pain, hip pain, etc. Talk about shoe wear, and then remind them about, as you're doing your evaluation, subjective part, you want location, quality of the symptoms, sharp, dull, burning, aching, type of pain, is it constant, intermittent, intensity of pain, and we'll discuss a little bit about red flags for the region. As we go on to the objective exam, you start with standing exam as usual, the lumbar and lower quarter clearing, lumbar quadrant test, extension, side bend, rotate to that side, rule out some neurological by doing heel raises, heel walks, etc. Observation, look for alignment. Again, a typical thing is looking at ankle bulk, muscle bulk, look at a gastroc soleus. Dynamic exam, heel raises, the importance of there is looking at quality of the heel raise. Do they have full supination as they get to the end range of the heel raise? As their squat, they're able to get the tibia and the torso parallel to each other. Does the hip break parallel? Look at the lunge, look at the quality, again, quality, quantity. Single leg balance, one of the key points to that is looking at weight shift. So we want to see, does the patient maintain the same height as they go from both legs to a single leg? That's important to see. As they lose it, there might be a lack of motor control in the hips or ankle. Exam-wise, we can go through the swing test exam. You can go through, the video has that. But it's the idea to see how much dorsiflexion and plantar flexion, to see how much is dorsiflexion involved with the posterior talar glide. As we continue, you look at supine, look at swelling. We talk about different types of swelling. Was it post-injury, or is it more from versus a red flag? Infection, clots, venous insufficiency, heart problems, liver problems, kidney problems will give you some swelling to the feet. Look at calluses. Remind calluses are areas or anywhere with poor fitting shoes, etc. Through palpation. You go through palpation starting immediately, and you're going to work yourself around the foot. And we'll start medial malleolus, and you're going to be able to palpate around it from the anterior posterior medial part. You go to the mid part, go 1 centimeter inferior to the medial malleolus, this is substentaculum tali. You want to be able to palpate neck of the talus and work your foot down. Remember, on the top, anterior tib with dorsiflexion. Navicular tuberosity, if you work your way down to the foot, you'll feel that component of it. Remind yourself of all the medial ligaments, and then we're going to go through palpation of the muscles as they go behind the malleolus. We're going to start with Tom, Dick, and Harry, tibialis posterior, straight behind it. If you work your fingers up about 2 or 3 finger widths above, and you go towards the Achilles tendon, next thing will be flexor digitorum, and you'll feel as they flex their toes, and go even more lateral towards the Achilles, the flexor hallucis longus. As we continue in that area, you also want to find the tibial artery, which is at the top of the dorsum of the foot, at the ankle, medial lateral to the extensor hallucis longus. Follow it down, it'll be lateral to the extensor hallucis longus dorsalis pedis. As we continue, now we're going to go more towards the lateral side of the foot. Lateral malleolus, go straight down from that onto the calcaneus, the trochlear, peroneal trochlear, where you're going to have the fibularis longus and brevis. The fibularis longus will go across the foot and go opposite to the first met. The peroneus brevis will go right to the 5th metatarsal. And if you go anterior, fibularis Tertius will be the top of the foot, and they'll go to the top of the fifth metatarsal. If you work your fingers down, you go towards the fifth metatarsal, the edge of it, follow it back, and you go straight up and you hit the cuboid. You also want to be able to palpate all the lateral ligaments, the anterior talofib, the calcaneal fib, and the posterior talofib. The dorsum of the foot, you want to follow at the neck and the head of the talus. We talked about the blood supply before, neural structures going through there. Posterior foot, we want to be able to palpate the calcaneus, the Achilles, and then go onto each side of the Achilles to find the soleus. Continue the exam. We start going up and we go through the active and passive range of motion. You can do it in sitting wise, you can do it in sitting, you can do it supine or even prone. But you can go do dorsiflexion, you want to think it through metatarsal joint, and then localize it more mid-tarsal joint. Same thing for plantar flexion. Inversion, we look at subtalar inversion, eversion, and then go mid-tarsal inversion, eversion. Resisted testing, you can do gross testing. If you want to find contractile lesions, go specific muscle tests. Posterior tib is a plantar flexion inversion. Anterior tib is dorsiflexion inversion. Fibularis tertius resist eversion with the foot in full dorsiflexion. Fibularis longus and brevis resist eversion of the foot. And if you do it more for the peroneus, the fibularis brevis, you resist more of the outside of the foot. Fibularis longus more toward from the medial side of the foot. Continue, you can go through your passive accessory exam. You can go through each of those joints, do the glides in each direction. Then you can see if you're not sure of the specific testing, you can look at the videos attached to it. As we go, tendinopathies, the Thompson test, where you grab and you squeeze the calf to see if the ankle does plantar flex. And then we can go through some of the prone techniques. We can do the same thing. All the passive accessory glides can be done in that position as well. From there, you get exercise progression. We talk about mobility, trump stability. You can go through some joint mobility testing, soft tissue techniques for all the muscles we talked about, joint mobs specific, go joint by joint. And then we talk about, again, by positioning, stability, strength, by position, lying, sitting, standing, surfaces, etc. And we're going to talk through definitely the lower body progressions, how you would progress the patient. We're going to do next week is weeks 11 and 12. These are open weeks. During these weeks, you're going to be able to do whatever you missed or you think you need to spend more time with the student on these weeks. Have them bring case studies, talk about problems with techniques they're having, etc.